Hello everyone, I'm Ron Leavitt. I'm Director of Audiology at Corvallis Hearing Center. I'm here today with some friends and colleagues of mine of 30 years or so, and some of them are lifelong hearing aid wearers and some of them are just long-term hearing aid wearers. All of them have been part of the Oregon Association for Better Hearing, which is a consumer informational group that is now in its 31st year of meetings every second Thursday of the month at our local hospital here in Corvallis, Oregon. I brought this panel together because they all have both professional and personal interest in the topics we'll be discussing today, and they're the right source for these questions because they have worked professionally in the audiology or hearing rehabilitation profession, many of them, and have been involved in important legislation in those areas for these many years. And there's been some changes that have occurred just recently that have given us pause for concern, and we want to address some of those questions as well as questions we typically get at this group that meets for the last 31 years. The first thing we want to kick off is the issue of what the Food and Drug Administration has been doing. Just this month, December 7th of 2016, the FDA commissioner announced that he would no longer enforce the requirement that people 18 years of age or older require a medical evaluation or need to sign a medical waiver prior to obtaining hearing aids. Secondly, he is considering the allowance of a new class of hearing aids that can be sold over the counter. Now, if you've been on the Amazon website recently or looked in the back of Parade magazine, you probably realize that hearing aids are already being sold this way. It's just now that the Food and Drug Administration has green-lighted this self-diagnosis and self-treatment. So you might ask yourself, how did all this come to pass? Well, it had to do with a panel that was convened by the Institute of Medicine, now known as the National Academies of Sciences of Medicine and Engineering, and they convened a panel of experts who came up with 12 recommendations, which were published back in June of this year, for ways that they could make hearing health care more affordable, more appropriate, and more efficient for people to access. And the driver of this group was a Dr. Frank Lin from Johns Hopkins Medical University, who has both a PhD in public health as well as an MD. He's an otolaryngologist or an ear, nose, and throat surgeon. And his research over the past several years, along with his colleagues from Johns Hopkins, had discovered a number of conditions that exist in concert with hearing loss, including more frequent incidence of falls, higher incidence of depression, greater rate of mortality, but most notably, what's gotten the greatest amount of publication is his work in all-incident dementia relationship to hearing loss. Specifically, he found that people with mild hearing losses are 1.89 times more likely to experience all-incident dementia. People with moderate hearing losses 3 times more, and people with severe hearing losses 5 times as likely to have all-incident dementia, including Alzheimer's. So we've suddenly become very interested in the relationship of hearing loss to all these other devastating conditions. But in his same presentations, when he speaks as a public health specialist, he has also noted that because there's a rare incidence of medically treatable ear problems amongst hearing aid wearers, that it probably is making it less affordable and less accessible to require this medical evaluation. And the FDA bought into this and green-lighted this suggestion, as well as his suggestion for over-the-counter hearing aids. So that's how we got here. But I wanted to ask this panel of experts how they feel about this, and let me introduce them to you, starting on my left, your right. Dr. Kevin Marshall was the original founder of the Regional Resource Center on Deafness at Western Oregon University, and he taught vocational rehabilitation counselors how to work with people that had hearing loss. So he's had a life career of working with people with hearing loss, and now himself a hearing aid user, has both professional and personal perspective on this issue. Next to him is my colleague of 31 years, David Veers, who is past executive director of the Southwest Washington Center for the Deaf and Hard of Hearing, and has been past president of the Hearing Loss Association of America Portland chapter many times over, and has been very active in this state as an advocate for people who are deaf and hard of hearing. Also himself a 30-plus year hearing aid wearer and now cochlear implant user. Next to him is Nikki Clark. She is Director of Operations here at Corvallis Hearing Center and sees patients every day for these many years, and is herself a lifelong hearing aid wearer. Next to me is Colette Welch. She is a lifelong hearing aid wearer who was my audiology assistant nearly 10 years ago and is now currently working on her doctorate in audiology at City University of New York. Next to me on my right, your left, is David Curry. He is past executive director of the Northwest Association of Schools and Colleges, and also a longtime hearing aid wearer now. And next to him is Andy Evans, who is very active in the regulation of hearing aid licensure in this state in the past, and himself a longtime hearing aid wearer. And finally on the end, Liza Knowles, a 20-plus year hearing aid user, previously a vocational rehabilitation counselor who worked extensively with people with hearing loss, and now is currently trying to help all the state agencies become more accessible to people who are hard of hearing and deaf. So you can see that we have quite a panel of experts here with their unique perspective, both personally and professionally, in the area of hearing loss. So with that being said, let's get started with our questions. Number one being, what medical problems might you think would occur if people are allowed to buy hearing aids over the counter, as is very likely to come to pass? It really already has if you look on the internet. Let's start down here with Kevin. What do you think about that, Kevin?
Well, excuse me, the first thing that comes to mind is that people will be doing self-diagnostics without any knowledge of what could be there in terms of medical issues. Various medical issues will have the potential to increase and cause, increasingly serious long-term implications for the people if they just buy an over-the-counter hearing aid and assume that's the only reason that they have hearing loss and the only thing they need to do. And various ads you see in AARP publications and other things sort of verify that. Try this on; it will help.
David, do you have anything to add?
One of the problems I see is people's hearings will change, and if they get it over the counter, they may feel that is going to be fix them up for the duration, and they won't even notice that they're getting less and less benefit from these devices as their hearing progressively declines. So that's a major concern of mine as well.
Well, in the clinic, we see daily that there's earwax inside the ears, there's ear infections, and a lot of the times the patients don't know. And you can't see in your ears. And if you try to buy a hearing aid and cram that in your ear without anybody looking inside your ear or treating you for any ear infection, then not a good thing. You're just putting something over the top of ear debris.
We recently did a report at the Academy of Doctors of Audiology where we looked at 176 hearing aids that had been fit throughout Oregon in facilities other than this facility here. And we looked to see the extent to which those hearing aids conform to well-established mathematical targets for the individual's hearing loss using something called real ear measurement. And on our website, we have some reference to a video Andy did some years ago about real ear measures, but essentially is putting a measuring microphone at the eardrum and looking on each individual's ear the extent to which the hearing aids are correcting their hearing. Well, that is considered best medical practice in our profession by all of our national associations. Unfortunately, when we looked at these 176 hearing aids, we found that only 2.7% of them came anywhere close to matching these targets. Stated differently, nearly 98% of the hearing aids that we looked at had no relationship to the individual's hearing loss. So I'm asking now in this question here, what do you think about the difference between best hearing aid science programming using real ear and typical practice in this state? And this time I'm going to start down on this other end with Liza, because she had the audacity at one point in time when she was a vocational rehabilitation counselor to call people and say, why aren't you doing this? Liza, why don't you start off?
I think it's a serious concern, and it's something that I really tried to help my colleagues to understand when I did work for the State Department of Vocational Rehabilitation, that hearing loss is not a minor issue, and that using the latest science to try to approach fitting outcomes and understand them objectively was much more important than the subjective user reports that we had relied on prior to that in our vocational rehabilitation system. The idea is that you would just survey the clients on how well they felt that they were doing with the hearing aids after they purchased them. And I think that was misleading, and it's difficult for a new hearing aid user to really understand the features that they're being offered in a hearing aid. It's difficult to understand whether or not they're working appropriately. To a new hearing aid user, even a mild change is a big change. But they may not necessarily know how to question their own speech understanding ratings, know which tests to ask for, and what the results would even mean. So that's why I think it's really important that those are interpreted by a medical professional.
People often ask me, and I say, well, I haven't heard this directly, but you actually have. Why do you think people don't do this more? Why do people not use best science practice of real ear more? What kind of answers did you get?
Some different answers. And I think at the time, and this was a few years ago now, the type of answers I was getting, well, let's see, how do I put this? The equipment is too expensive, or it's broken. And sometimes I would call back a few weeks later to see, is the equipment back up and running, and get the response that, why are you asking us this? I got a little bit of pushback from audiologists that didn't necessarily, I think, feel comfortable with the technology and didn't want to talk about why.
I'm sure you're speaking truth on all of that because we've all seen it. But I think there's just too many parameters that we've discovered that come together to make a good quality hearing aid fitting. And what we've really discovered, and I'm sure, Liza, you'll remember this, is most practitioners out there aren't even measuring the right things in order to do the correct fitting. And it really is complicated. And what you said, that the user really isn't in a good position to know what it takes. Typically, you're going to be uncomfortable with the proper fitting for a few days while you get used to it, and once you're used to it, you'll understand what it's giving you, and you won't want to go back after that. If somebody were to revert to the the adjustments you had when you first put it in that you thought were comfortable, you would feel cheated. You wouldn't have the ability to function at all. And I'm just going to say that when we looked into this, the practitioners out there, number one, they aren't measuring what they should measure. They're not even asking what they need to know. And then number two, if they don't ascribe to the correct practices where they're balancing the audibility relative to what the user can comprehend, then a person just isn't going to get the right fitting. It's just not going to happen.
People say to me, I've got to have a volume control on this hearing aid. Yet, if you've been watching this panel of hearing aid wearers, all with very different degrees of hearing loss, you don't see them reaching up and down to get their volume up or down based on who's talking. So my question to all of you users is, why are you not constantly adjusting your volume? Let's start with Kevin.
Well, to be honest, the only time I use a volume adjustment actually would be more like an on and off switch, because if I'm at a rock concert and I want to turn it off, I will do that. Otherwise, it's a benefit at some level, and depending on the loudness or the, what's happening in your background. But I don't ever use my hearing aids in a modified position or anything. I either turn it off or on, and that's just very seldom do I turn it off unless it's an extremely loud situation.
And the research supports the idea that maximum correction for your hearing loss all the time will give you better speech understanding in noise. Yes, it'll be noisier at a full correction than if you turned it down, but if you turn it down, your speech understanding will suffer. David, you were not a hearing aid volume chaser in your hearing aid using days.
Well, now I'm a bilateral cochlear implant user, but this has been relatively recent. I've had 30-some years of experience with him before I got the cochlear implants, so I'm well versed in this. And if they're properly programmed, you don't seem to need to change the volumes at all. Right now with the cochlear implants, I have a remote, and the only thing I use the remote for is to turn on the T-switch on and off to use with my Quattro type assistive device for hearing on the cell phone. And that's pretty much it.
The same goes for me. I do not use my volume control, or I don't really remember the last time I had a volume control, to be honest with you. So honestly, if your hearing aids are properly programmed and all the specific frequencies that I was talking about before, if those have been touched on, chances are you're not going to need to go into different environments, like say a restaurant, and be turning that hearing aid down. It should be set to where you can tolerate the noise in a restaurant, and you get the speech understanding that you need, and you can understand the best that you can possibly can. So as a whole, I can't tell you the last time I really, really needed volume control. I guess with your comment about turning it off completely, the New York City subway is very, very loud. That might be the only time I turn it off for like 5 seconds until I'm out of the subway. Other than that, my hearing aid is on all the time. One last thing I want to add, because we're talking about the uncomfortable listening levels, a little bit different from what you just said. There's this thing in the profession where some people believe that you can use an average uncomfortable listening level. So basically what that is taking a study that was done. I don't know the exact number of participants, but I know that they, based on their number, they averaged the values. And so basically what they're saying, for a certain amount of hearing loss, this is your uncomfortable listening level. The problem is, I don't fit in that category. I don't know how many here fit in that category. So the problem is, if you're just using those average values, you're not going to appropriately fit that hearing aid and make it to where it's appropriate for them. It's either going to be too loud, or you're going to unnecessarily make that hearing aid a little too compressed. what that means is basically you're doing stuff that you wouldn't need to do. And Dr. Leavitt can further comment on this topic if he wishes.
I could talk more about that, but I think you covered it nicely. You were referring to David Pascoe's doctoral dissertation back in the 70s, and Ruth Bentler and her group at University of Iowa said, okay, let's see the extent to which we can correctly estimate your uncomfortable listening levels based on your thresholds. And she looked at over 600 ears, 675 maybe, somewhere in that neighborhood, and she found that very rarely did they ever conform to the average. And what Colette said is important. If you're not giving people the maximum range of sounds they're capable of hearing within their tolerance, then you're cheating them that way. By contrast, if you're making them too loud, you've created a hearing aid that they're constantly going to be chasing the volume up and down. So you really need to take that measurement into account. As Andy said, you have to fit at all these different levels to get an appropriate fitting. It's not just a matter of simply turning it up and blasting away indiscriminately. And that can be dangerous, as Liza referred, to people who have very severe hearing losses and need a lot of power. You don't want to. We just put a new hearing aid on Colette maybe an hour ago, and one of the things that we were looking at was making sure we didn't get the loud sounds too loud, because both she and Nikki really like loudness, but to a certain point. I'm going to shift gears and move us along here a little bit. In this profession, there is a variety of things audiologists do. We do balance testing and balance rehabilitation. We do industrial noise control and help workers protect their hearing in noisy industries. We help people who are having various surgeries on the ear to make sure that they don't lose their hearing in the midst of that surgery. They call that intraoperative monitoring. We do a whole host of electrophysiological measures from birth for some children to see, for all children in this country virtually now, to see if they pass the newborn hearing screening, all the way up to adults who are suspected of having acoustic tumors and a variety of other tests. And we have a very diverse set of things we do in terms of diagnosis. But oftentimes I've heard people say in this profession, well, we've got to be careful that we don't just become a bunch of hearing aid dispensers. And oftentimes I've seen in the many places I've worked, hearing aid provision is sort of what you give the new people, and it's considered less exciting than some of the diagnostic measures. So my question to you folks is, how do you see the balance between diagnosis of hearing problems versus rehabilitation of those hearing problems? How much emphasis, given we don't have an unlimited amount of time for each of you, do you want us to spend on diagnosis versus rehabilitation, which might include cochlear implants or hearing aids and hearing aid programming, as we've been discussing? Kevin, we'll start with you.
Well, speaking as a rehabilitationist, you can't do rehabilitation until you know what your issue is. So, the first item, it has to be done and done with as much precision as possible, and then you can work on the fix, the rehabilitation. So I'd say it's definitely a 1-2 step, and without the rehabilitation, everything else is just guesswork.
Basically, I agree completely from the standpoint that we've pre-screened these questions, so I had an idea as to how I wanted to respond to that, and I wrote down, how do you separate the two? You really need both to do a proper job of servicing that particular client. I don't see either or, it's got to be both.
I really think it's important as a clinic to see the patient with their hearing test results, and then seeing the final results of their hearing aid fitting and how they're improving. And we do additional testing and diagnosing after the hearing aids are fitted on them. And they're all very important. I think it's good that as an audiology, as a clinic, you have both.
So my comment on this is just adding to kind of what we've already been talking about. So we've been talking about the issue with over-the-counter hearing aids, and what happens if that person who purchases the over-the-counter hearing aid has something in his or her ear. And say, for example, that person didn't really need the rehab of a hearing aid. you can imagine that making that error does not go along with what you guys are talking about. It does not go along with doing the diagnosis first, because in this case, the diagnosis was missed. And so when the diagnosis is missed, there's the improper rehab that goes along with it. So there's a very important two-step process that we've been emphasizing, and this is just an example that I'm reminding you guys of that could happen if you miss one step. Let's say, on the other hand, if you miss rehab, if you miss the rehabilitation process of hearing aid fittings, you're going to have the person who might leave their hearing aids in the drawer. So they really do go hand in hand. You need to follow up with that patient, but you also need to find out what is their issue. Is it something in the ear, or do they have hearing loss, and do they need the rehabilitation process? So those are just my thoughts on that question.
One more thing I want to add is there's also some hearing losses that can actually be treated just by surgery. And if that person skips right over the diagnosis and goes and gets an over-the-counter hearing aid, when surgery would have fixed their hearing and restored them back to normal, we actually saw a patient 2 years ago who had this issue and jumped straight to a hearing aid, and we said, no, you don't need a hearing aid. And she came back and she had normal hearing, very close to normal hearing after surgery.
And you might think that, well, a person who has not had good medical training could perhaps miss that sort of thing. But I should mention that this person she's referring to is a college professor. It really isn't true that just because you're well educated, you can self-diagnose well. And when this person discovered that, you didn't need to be doing this all these years with this hearing loss and going through all this, you just need surgery. She was kind of surprised, and I said to her afterwards, when she had normal hearing after having a moderate to severe hearing loss, I said, it must have been quite a shock. And she said, well, it was for a day or two, but now I'm over it, and I'm just used to having normal hearing, which was odd, and I kind of see it from you two, actually. Oftentimes I'll say to them, do you hear better with this hearing aid? And they'll say, yeah, but not very excited about it. You adapt quickly to the new bar being raised in what you can do with your hearing. One of my old mentors used to say to me, when I see serious errors occur, it is because something was done wrong at the very front end, and then everything done thereafter compiled those errors. And I think he's really onto something there. There's a shocking number of people that we see who have been wearing hearing aids, and no one has ever looked in their ear, only to discover that they have an inch worth of earwax in their ear that needs to be dug out over an hour period. We see this fairly routinely. In fact, we have been analyzing since this FDA statement came out in December, how many people we have seen that actually do have other problems that need to be addressed before the hearing aid. And Ashley tells me, my assistant, that it's somewhere in the neighborhood of 28% of them have other problems that needed to be looked at before we ever got to a discussion of hearing aids. And that questions Dr. Lynn's rare occurrence thesis that the problems associated with hearing loss are so rarely medically treatable that they do not warrant a medical requirement by the FDA. I'm in complete disagreement with that. Next question. This is one of those other questions that we get on the phone quite often. How do I know when it's time to get my hearing aids? How do I know when it's time to do something to get a hearing test? I'll ask each of you, how long did it take you between recognizing you had a hearing loss and doing something about it, Kevin?
Well, other than when my wife kept telling me I needed it, I think something you said earlier about we adapt to like a better hearing aid, and we're very adaptable. In the reverse, we're also very adaptable to the loss, which happens over a long period of time, most often, and we adapt very readily to that. So this subjective kind of knowing when you need to wear it, like like the FDA is apparently saying now, whenever you think you need one, go into Costco and buy yourself an over-the-counter hearing aid. That flies in the face of all the science and research that I've seen.
I didn't really wait. I was 3 years of age when it was discovered that I had a hearing loss, and I was fit with a hearing aid right away. And to back up what Kevin said, hearing loss for older adults is a very slow decline usually, and when you have that slow decline in hearing loss as an adult, you are missing those speech sounds very slowly, so you don't notice them, and you don't know what you can't hear until you get that hearing aid on. Then you realize, oh, I can hear the clock ticking. I thought I didn't work anymore, or I just got a new car and I just thought, oh, they don't have the clicker on the turn signal anymore. Well, now they can hear all those sounds because they have their hearing aids.
Mickey and I have had sort of similar stories. I was also diagnosed at about 2.5 or 3 years of age. However, certain things I've been finding out since discovering a medical file on me. Let me tell you, that's been an interesting process for me. But what I want to get at is that I didn't immediately get a hearing aid, and the reason for that is actually very significant. It's very important. There was a long medical process involved in all this before I ever got my first hearing aid. So what I'm getting at is, despite the fact that I didn't wait technically to do something about it, the medical process was something that was involved with me because there was other stuff going on. And without that, like say, had my mom thought, oh, she just has hearing loss and went to the over-the-counter and got me a hearing aid, it probably wouldn't have been in her best interest. In fact, it wouldn't have been in her best interest is probably what I can say with all the knowledge that I know now, that it would not have been a good outcome for me.
So are any of you in disagreement with the opinion that you should get to it earlier rather than later?
Dr. Frank Lynn did some very good research starting in about 2012 or so, for several years. He was the one that pretty much established the connection between hearing loss and medical disability, and kind of going going forward towards the idea that maybe that would open up some of the other programs, insurance companies, Social Security, some of those things, to buying hearing aids or Medicare, which haven't traditionally done that. And he did a pretty good job of establishing this, and then suddenly he has gone the other way, which it kind of puzzles me. But some of his research, there was the Baltimore longitudinal study was done over a period of 10 years, where they studied 126 people, I guess, and gave them functional MRIs every year to study brain volume. And people with hearing loss lost 1 cubic centimeter of actual brain tissue for each year. Now, whether this is directly related to your speech and understanding and things, I don't know, but I would say that area of the brain, which is responsible for many speech and hearing and cognitive functions, losing 1 cubic centimeter per year, well, in 10 years, so you've lost 10 cubic centimeters. It's got to be a really impactful thing that's happening to you, even if you can't directly relate it to a specific symptom. So I think this all feeds into the idea that early diagnosis is imperative, and the longer you put it off, that's that many more cubic centimeters.
All I was going to say is that the data that we're talking about is it was done on individuals with untreated hearing loss, so individuals who did not pursue hearing amplification or any other assistive technology. So that's an important factor, because that's one of the other things that researchers, I think Franklin included, they're looking at, okay, when you put on a hearing aid, what does that do? So
the longer you wait to get a hearing aid or even try a hearing aid, the harder it is to adapt and get used to the sounds of a hearing aid. A hearing aid is not like normal hearing, nor will it make you normal hearing again. But all those speech sounds and other sounds around you can be very overwhelming. And if you start way late in the game, after you've lost a lot of hearing, it can can be very difficult for you to adapt.
There's some new work at University of Colorado Boulder now that is looking through functional MRIs at brain area reassignment. And by that I mean that Dr. Sharma, who presented recently the Academy of Doctors of Audiology, showed that when people are denied audibility of speech, they start using other areas of the brain, recruiting other areas of the brain to help figure out what's being said. The prefrontal areas start kicking in, trying to make meaning out of partial messages. And her work has shown that both cochlear implants and hearing aids will help reassign those areas to their appropriate function. And she believes that Dr. Lin may be onto something with one of his hypotheses about the relationship between all-incident dementia and hearing loss, in that this reassignment, she believes, is overtaxing the brain and putting audibility back through a complete fitting, as she pointed out, verified by real ear measures, will allow the brain to essentially relax and go back to its normal functions. So there's some new evidence that Frank Lin is really on the right track with his thesis about overworking the brain and overusing cognitive resources to try to make sense of speech. When you hear discussion around why we need to rework the hearing healthcare system, one of the major issues is price of hearing aids. You hear various numbers quoted, somewhere in the neighborhood of $2,000 to $2,500 per hearing aid, and the thesis there is that these prices make hearing aids unaffordable to many people. And certainly that is true, that hearing aids do go at those prices in this country. Top-of-the-line hearing aids, that's a fairly typical number. That being said, I think we should take a look, and people have pointed this out to Dr. Lin on numerous occasions, me being one of them, that the Veterans Administration, through their bulk purchasing, purchases 20% of the hearing aids in this country, and because of that, they get those hearing aids at prices comparable to the over-the-counter hearing aids that Dr. Lin has been recommending, some of whom, incidentally, have gone out of business now, which suggests they're not working that successfully for people. But my point is that these group purchasing options would allow all of us audiologists to provide hearing aids at dramatically reduced costs. The Veterans Administration is purchasing these things at the same price as over-the-counter hearing aids. So the idea that hearing aids are inherently expensive does not hold up if you look at group purchasing options. What are realistic expectations for a hearing aid user after appropriate hearing aid programming, meaning real ear programming, has been achieved? For example, are you going to understand speech in noise in every situation? Are you going to understand every word that a person says to you? Talk a little bit about that, Kevin.
Well, I'd say persons with normal speech can't do that, so I wouldn't expect to do that with using hearing aids or assistive devices, but I would expect it to maximize the potential that I have, and if that doesn't quite reach the hearing level of someone who's 18, I guess I wouldn't expect that, but I would like it to increase my ability to understand and participate and be part of the program.
As I said before, hearing aids do not restore you back to normal hearing, like David just said. They can only assist you in the region that you are missing critical to speech sounds. For me, without a hearing aid, I hear 0% of speech sound. With the hearing aid on, I hear 68% of speech sound. So I'm still missing quite a bit of speech sounds in with my hearing aid on. But hearing aids are confined to what's called the half gain rule, where they cannot restore you back to normal hearing, because if we did, it'd be way too loud and you could probably damage your hearing, the remaining hearing you have left.
The other night, Ron and I were talking to a colleague of ours after a concert. Without these to clip onto their collars, I was out of the conversation. When I clipped them on, I was in. It's the difference between, for me, being in or out.
Do all of you think that premium level hearing aids, the most expensive type, will give better speech understanding in noisy places than basic hearing aids, provided that both are programmed exactly the same using real ear verification to prove they're exactly the same?
I have tried both basic, and then there's a medium level and a premium level, and I do the same with the hearing aids as long as they're programmed properly using real ear. I have not noticed anything other than with the premium hearing aids. Sometimes they have features where it goes, well, let's do directionality, and it'll move the microphone and do all these other changes, and that makes it very hard to follow a conversation when those hearing aids are making those changes and you don't want them to. I would rather have all those features turned off on the premium level hearing aids, because it just makes it way too confusing trying to figure out what the hearing aid's doing and making those changes.
Yeah, the only thing I have to say on this topic is, well, I'm agreeing with what Nikki says, that there's really no difference when you put the low level to the high level technology and you fit that with real ear, the hearing aid alone. What I would like to add to that, though, is the only difference I'm starting to notice is that when you do a very, very, very basic hearing aid versus the mid-level technology, there will be occasional times, not all manufacturers, but some manufacturers will take out the additional features such as the ability to connect to your phone. And when you do that, that is when I would say, okay, you might want to consider the mid-level. However, I don't think there's been an instance when I would say the high level has been the most needed for somebody.
My answer is maybe. I've witnessed where there's might be a narrow set of circumstances where some of those very premium features might work, but the truth is that I've discovered is there's always trade-offs, and the trade-off might be that yes, you can prove that directionality works, but like Nikki says, it's very annoying and very confusing, and I had numerous occasions where one ear would get more noise and it would get quieter because of that. This is a noise canceling strategy. And now you're in an unnatural setting because you kind of want to know where the noise is coming from, and you just lost it in the direction that it's coming from. So there's these trade-offs that you have to weigh very carefully. And like I say, there's narrow conditions where maybe some of those features are really good, but then there's others that maybe they're not. And one of the trade-offs, obviously, is extra costs.
I'd rather have the hearing aid be predictable, and that's more important to me than zooming features. I've had those before and been talking to someone in a vehicle, and all of a sudden the road noise goes up and then it comes down, and then it's focused on the back seat, now it's focused on the front seat. So it wasn't something that I felt was useful at all. As far as the cost, I'm all for making cost of hearing aids transparent, unbundling the services, making it so you can do apples to apples comparisons of hearing aids, so the consumer has some understanding of what they're getting, what they're doing. I guess that's all I want to say.
Question. I have people come in and say, I want to make sure I use all the programs that this hearing aid offers. Some hearing aids have different settings for different environments, and the user can manually switch through those environments. For example, there may be one for listening in quiet, listening in a restaurant, listening in a car. My question is, how often do you folks use more than your automatic program that's the default program? Kevin, how often do you go to another program in your hearing aid?
I basically don't. As I kind of said previously, if something is too loud, I'll actually turn it off. I have an off button, a remote one. But beyond that, I don't fish around and look for different levels.
I have the potential for 4 programs on my CIs, and I use one I've been trying to get a second program that will kind of reduce some of the low pitches in order to be able to hear in the automobile or that's the particular one, is to reduce the road noise. And the reality is that we've had 2 stabs at it so far, and none of them work. So I use the number 1 program because I'm able to function better with it than any of the attempts at programming for road noise.
I also don't change my programs other than going to this mini mic. You have to change your setting in order to go to that. However, on Sunday I was at brunch and we had 12 of us at a table, and I really wanted to listen to everybody, be able to understand a little bit better. So I did reduce my low frequencies just a little bit in the software, or not in the software, on my phone. I have the ability to reduce the low frequencies independent of all the other frequencies, and that did help some with the plates and dishes that were going around and all the background noise. So it was useful to be able to do that as well as lip read.
For those of you who have external microphones that you use, if you were forced to choose between either a different program like the restaurant program or the external microphone, which one would you take and why?
It would be an external microphone for myself as well. It's nice to have a backup option, but I do find that the restaurant program, there's no difference with the restaurant program versus my default program, but this is the best option for me.
I'm in agreement with Nikki. The external mic would be the best option for me. That is, whether I'm in a restaurant, I would not actually go to the restaurant program. I would go to the external mic. But the second most, probably more important reason is that I use the external mic in what I do. It helps me when I'm in the clinic because I do a lot of testing, and there's this thing that we do speech testing, and if my supervisors want to listen in on what the patients are saying, the sound comes out of the speaker, so that it's no longer right at my ear. And that, for me, is the problem. So I came up with a solution, and that solution is putting this on to the patient so that I can hear them and I can actually score their speech scores accurately without getting stressed out and without feeling like I can't do my job. So for me, it's an essential tool in order to succeed.
About half of the places where I tutor, I have to have the external mic. So it's essential or I'm out of business, literally. Otherwise, they'll give me a room that's too far away. I lose too much in travel time. I won't give you a lot of war stories, but it just doesn't work unless you're willing to work in the hallway in noise in my situations. I don't have any other program, so I can't talk about what I would do if I had one. I just have a program that says listen.
What portion of hearing aid purchase does Medicare cover? I'm going to start with Nikki.
Medicare does not cover hearing aids, or hearing aid services. However, they can cover hearing tests. They do not cover routine hearing tests, but they do cover a hearing test if it's medically necessary, and you need to have a referral from your doctor.
Will my insurance cover hearing aids?
You would have to look into your insurance and call them and see if they'll cover a hearing test or hearing aids. You can also call the audiology office and ask the insurance specialist there to check into your insurance for you, because we have the codes and know what to ask for. And sometimes we get weird answers back from the insurance companies, but it's better to have the audiology office check for you, because they know exactly what to ask for.
How long does your battery last in typical use, assuming that you take off the hearing aids at night and open the battery door? Kevin?
Excuse me. About 2 days, give or take, maybe 2.5 days.
Your battery is 2.5 days?
Yeah, that's about all it does.
It depends. If I use the wireless accessory excessively, I get about 3 days. If I don't use it at all, I'm looking at about 5.
Mine is the same as Nikki. It's about anywhere between 3 and 5 days.
Should I tell my doctor if I'm concerned about my hearing loss? Start with Kevin.
I'd say absolutely. Again, this is in that subjectivity thing, because quite possibly before you realized you had hearing loss, you probably did have significant loss. But as soon as you realize it, or it comes to your attention from someone else or something else, yeah, absolutely, because it could be the whole range of problems from severe medical issues to earwax. So.
I think this is very important, but it's also important if you have Medicare, because now instead of you paying out of pocket for your hearing test, you can have Medicare pay for your hearing test. But you need that referral from your doctor, and how you get that is by going to your doctor and saying that you're having trouble hearing.
Yes, you definitely should be talking to your doctor if you're concerned about hearing loss, or even if you're a long-time hearing aid wearer. Make sure your doctor is aware that you have hearing impairment. Several reasons are for this. I could probably tell a story about this, but I'm going to keep it limited to one example, and that example would be if you are having any communication breakdowns with your doctor. It would be important to make sure he is aware that he will need to be facing you in order for you to make sure that you fully understand what is going on, not just about hearing loss, but about any other medical issue you could possibly be having.
We, in our clinic, routinely write a comprehensive report on every single patient, whether they were referred by doctor or not, so that we have that information available for all physicians, because we do like to have the physician in the loop of this. And these reports also offer an excellent opportunity to talk about what we know in this literature, what the research has shown, what is new. Physicians have to be responsible for the entire health care of a person. They don't have the time to study extensively our particular area of hearing loss. So the working relationship between audiologist and physician is, I think, absolutely essential. That being said, I thank all of you for being here, and I hope you enjoyed this. And if you want to know more about our program, you can learn more about us online. Our website is betterhearingus.com, and we will put this up on our website and on YouTube so people outside of Corvallis will know about it. Thank you to all of our panel for being here. It was a rare opportunity to hear from all of you.